Thank you, Raksha ma'am, for that nice and kind introduction. You are one of the reasons for me joining a fellowship, so thank you so much. So I'll be talking about retinoblastoma, most common intraocular tumor, and why I would like to start with the history. There is a simple reason that I will tell you in my third slide is the first description was done way back by Petrus Provis, and it was described as some tumor resembling a retinoblastoma, and he thought it was a fungal mass basically. Then James Wardrop, he first proposed that the early enucleation of the involved eye might save the life of the patient. So this is how it was started with, and then when we see today, what was the management history? So it was enucleation as it was prescribed by popularized by Wardrop, then enucleation, radiation, chemotherapy. That's how the protocol was. Now today when we see the protocol is totally reversed. It's chemotherapy, then radiation SOS, and then if still not salvageable, then only you go ahead with the enucleation. So there is 360-degree change in the current management compared to the old management. Now, how do you manage today? There are a lot of options of chemotherapy, focal therapy, radiotherapy, and enucleation. I will be just showing you this in the brief that the chemotherapy can be given in the various ways from intravenous, intraarterial, periocular, and intravitreal. Focal therapy consists majorly of the lasers, and the radiotherapy, EBRT, or the plaque brachytherapy. And the end is the enucleation. Options for treatment depend on the primary tumor or recurrence of the tumor and again the size of the tumor. Now, moving ahead with, since we are majorly focusing on the imaging and the diagnosis of the tumor here, what do we follow today? We follow an international classification of the retinoblastoma given by Shields, and the classification which is of very most important in the developing countries like India is orbital retinoblastoma. It was given by our very own Santosh Unama sir, and it is again classified into the 5 different classes: so primary, secondary, accidental, overt orbital, and microscopic orbital retinoblastoma. Metastatic retinoblastoma, the incidence is no less, but still it is seen, and the patient does come with the multi-system metastasis and the very poor salvage in such cases. So what are the features of the retinoblastoma? How do we not miss a retinoblastoma? How can it present in a various ways? So this is a very early presentation of the retinoblastoma. We must say that sometimes it presented as transparent small mass near the macula or near the arcade that is seen, and it is translucent and a very small feeder. As it increases in the size, it develops its own feeder vessels or feeder vessel and the vein, and then it increases in the size, and there is subretinal exudate. This is an exophytic kind of a tumor, and this is whitish in lesion and the whitish in color and elevated. Now, this is a very classical picture when you see an optic disc with dilated feeder vessels, and there are two tumors, one inferior and one superior to the disc. The one which is seen yellowish, whitish yellow in color, basically it's one with the retina draped over the tumor. This is nothing but an exophytic type of a tumor. The another which you see, it comes with the penetration of the retina and it is growing inside the vitreous. This is endophytic type of the tumor. So majorly when you want to morphologically classify, you can call it as an exophytic tumor or the endophytic tumor, depending on the clinical examination. This is a large endophytic tumor. When it diagnosed in the late stage, you don't see anything. There is no view of the retina except for the few vessels, and you directly see a tumor mass. It becomes very difficult to diagnose at this stage in time. We do see such cases still today of orbital retinoblastoma where the growth is protruding out. Patient does come with the proptosis and many times the intracranial extension. Now, what imaging you should do ideally once you see a case of retinoblastoma? Very important is you should do a examination under anesthesia, because children are not very cooperative with examination. You cannot do it like ROP screening where you know where you are supposed to see the lesion. Retinoblastoma, it's not like that. It could be a multifocal involvement. It could be at the pars plana. It could be a very small tumor which you may miss. So whenever you are suspecting patient presenting with the features of leukocoria, it's very important that you should do a EUA. What else you can do is ultrasound B scan, very classical shown ill-defined mass here with the specks of calcification. This is how the classical B scan of the retinoblastoma presents. Now, the other scene shown are basically pseudo retinoblastoma. We will come to that each specifically, but here, since the picture is there, I would like to tell you this is again a irregular, ill-defined mass. Again, few specks of calcification, but not very well adhered to the retina here. This is nothing but a Coats disease. Here you say finding this small connection between the retina moving to the lens again is difficult. This is what we find in a Phpv, where the traction, the retina has a traction, and it's basically a persistent hyaloid artery which continues till the lens. This is familial exudative vitreoretinopathy. Here we say the nodular astrocytoma, and here nothing but a vitreous emerge in a patient of the sickle cell anemia. So you need to look for calcification in such case. Again, only given a B scan, will you be able to diagnose this as a RB or not, or be no? Again, a clinical examination is must in such cases. Now, imaging wise, this is a CT scan picture of the two different retinoblastoma cases. Now, what do we should look for? Before that, should we do a CT scan in every case of the retinoblastoma? We may not suggest that you should do it in every case of the retinoblastoma. It's a focal tumor. The optic disc is very much visible. It is only at the macula 3 by 4 millimeter tumor, and you may not in the stage A, or you just have a 3 millimeter tumor, you may not do a imaging in that case. But you have a large tumor where the posterior pole of the retina is not visible, imaging is must. CT scan can tell you a good status about optic nerve also. Here I would like to point out, see the normal optic nerve here and the normal contour of the optic nerve and basically thickness. Here when you see there are multiple calcific foci near the retina, which is very classical of the retinoblastoma, and you also see a thickening of the optic nerve. So what you must see in such cases is a calcification, extrascleral extension, and the optic nerve extension, which is to be seen on this CT scan, which tells you that are you dealing with just the intraocular retinoblastoma or it has gone to the orbital stage, and accordingly you need to set your protocol. Now, why always CT scan? Do we do MRI ever, or is it that necessary that MRI has to be done? There is nothing like MRI has to be done in each and every case. If it is bilateral retinoblastoma and you want to rule out that it's not a case of pinealoblastoma, in those cases, MRI is very important to rule out that this is not a case of retinoblastoma. Otherwise, CT suffices. Now, this is just an example of a tumor to start with, and then post chemotherapy, it reduces to a very small size, and a patient has a salvage of the eye and the salvage of the vision in such cases. Now, how does retinoblastoma present? Clinical presentations, you need to know the very important ones. Very first is the leukocory or the poor vision, which is a white reflex. Many times the parents come that in the dark, suddenly there is a reflex of the eye which is different, and this leukocoria is most common presenting symptom in such cases. Orbital cellulitis is present in the late stages but can also happen in the early retinoblastoma because it's a sterile inflammation. Very need to be treated early, especially with the steroids, because we have seen cases orbital cellulitis not treated early can lead to a scleral perforation, and then you need to treat this as an orbital retinoblastoma. Patient do present with the red painful eye hyphema, and then we do suspect that this is just a case of trauma to the child. But again, never leave a case of hyphema or especially full chamber hyphema in a children, saying that this could be because of the trivial trauma that we did not understand. You need to do a ultrasound scan in such cases. It could be a pseudo hypopion. Again, such cases should not be only considered as a uveitis. EUA or the B scan surely finds out the mass in the retina. Strabismus is another presentation that we should not miss in the early age. Now, differential diagnosis. What is the differential diagnosis? Suppose we make a list. It will take whole of our day to discuss each one of this. So we'll be discussing major factors. Like this was a study done which showed that these are the most common massacre rates of the retinoblastoma: Coats, persistent fetal vasculature, vitreous hemorrhage, toxoperiasis, and familial exudative vitreoretinopathy. So Coats disease. Now, this picture I would like to show, and we'll come back to this picture after we finish with the Coats disease, that which one of this is Coats, which one of this is retinoblastoma. Another again, here you see the you see exudative retinal detachment and the subretinal mass and multiple dilated blood vessels. Again, question comes that which one of this is retinoblastoma and which is the Coats. Now, what are the features of the Coats disease? Very important features of the Coats disease here you see is the subretinal material in the Coats disease is yellow in color. In retinoblastoma, it is whitish, though not the only difference, but one of the important thing to look for in your EUAs. It has dilated peripheral vessels, telangiectasia, and they are of irregular caliber blood vessels. Very, very important features of the Coats disease that they have a telangiectatic vessels and they are much more of irregular caliber compared to the retinoblastoma. You do a B scan of these cases, you might find a total funnel shaped retinal detachment, but there will be no retinal mass, which is not of classical of retinoblastoma. This retinal telangiectasia can be very well seen, and if you're in doubt, the FFA is of very much of help to show you the telangiectasia widespread and the florid, which helps you to differentiate Coats disease from the retinoblastoma. Again, the reflex in the Coats disease could be yellow and this could be white. Coats disease most commonly is unilateral compared to retinoblastoma. Again, a FFA picture of the same. Now, these are the various presentations of the Coats disease and what I show you. One of this is anterior chamber cholesterosis, where you see with multiple cholesterol crystals in the anterior chamber. This is again a classical presentation of Coats disease. Sometimes patient present with the painful blind eye with the neovascular glaucoma, and again a total retinal detachment but no mass. Seeing all this and again revising all this, that we need to see is peripheral telangiectatic vessels, retinal detachment, yellow glow, and FFA if needed. Then there is one more classic article which describes the MRI features of Coats disease. It specifically talks about no to minimal contrast enhancement of the solid lesion, and the contrast enhancement that is seen in the Coats is basically outside the solid lesion than the inside, which is seen in the retinoblastoma. So there are certain features which helps to differentiate your retinoblastoma from your Coats disease on the MRI. Now, retinoblastoma classically in the MRI it will be a larger eye size compared to the contralateral eye. In Coats disease, it will be contrary. A V-shaped retinal detachment is again very classical of retinoblastoma on imaging compared to the Y-shaped retinal detachment that you see in the Coats disease. And the vitreous seeding, this can be seen on the very high resolution MRI, at least 3 Tesla, where you can see a vitreous seeding also. So this kind of MRI help you to differentiate your retinoblastoma from the Coats disease. Now coming back to our primary picture, there are yellow subretinal exudates and the calcification, which was very important feature here to diagnose, and this was retinoblastoma and Coats. Then here you go as a peripheral telangiectasias compared in this exudative retinal detachment. And here what you are looking at, your left hand side is retinoblastoma and your right hand side is Coats disease. Another differential important diagnosis is PHPV, or the persistent fetal vasculature. Now again a picture where you don't know, you see a UA that is it a retinoblastoma or it's a benign lesion of the PHPV. Patient again presenting with the leukocoria. So what are the features of PHPV? PHPV cases generally again are unilateral. They do have a presentation as a microphthalmia and secondary cataract, which is rare in retinoblastoma. You can find out this persistent hyaloid system on doing a B scan. On examination, you do see a Mittendorf dot or the barely visible hyaloid artery. Very important sign here is the dragging of the ciliary process, which happens, which is very classical of your PHPV compared to the retinoblastoma. Again, a few classical signs on the MRI is you can see a ciliary body and lens deformation, optic nerve atrophy, and a central stalk between optic disc and the posterior lens in cases of PHPV. So what were this lesion? Both of them were PHPV. This is not the traction exactly. This is basically a persistent hyaloid artery extending till the lens. This is how the patient was in the anterior segment and development of the lenticular opacity. Familial exudative vitreoretinopathy. Basically, the problem is with the periphery, and it's basically retinal ischemia, and the angiogenesis is not happening in the periphery of the retina. This is familial, so it is very important that you do examine the siblings of the patient also. The family history and the FFV are two important clues to differentiate your FEVR from your retinoblastoma. In two more numbers. Yeah. Ocular Toxoperiasis, another important differential diagnosis. This can present as a macular granulomas with the retinal traction and the vitreous traction in the early cycletic memory. Everything said and done, it is very difficult to differentiate toxoperiasis and from the retinoblastoma. It's a stable lesion, and the serial EUAs can easily help to differentiate it from the retinoblastoma. And there are certain miscellaneous presentations of idiopathic intraocular abscess, myelinated nerve fibers, large optic disc with coloboma, cataract, grade 5 ROP with total retinal detachment, toxoplasma choroiditis. All this do present with the leukocory, and a good EUA examination can differentiate it from the retinoblastoma. So to conclude, EUA is must and necessary in every suspect case. Adequate imaging is important, and keep the mind open and do not get affected by a primary retinal diagnosis. Second opinion is always of help in case of. I acknowledge my mentor, Dr. Santosh Unavasan, and all the speakers because they contributed to my knowledge each and every day in some part of my life. So thank you all for being here, and I stop my screen sharing.